Okay.
Good afternoon, everyone. Welcome to Nazareth Home. I'm Mary Haynes. I am glad to see all of you. I see some new faces, I think. Are there some maybe who have not been coming to these? Anybody new? Great. Well, welcome. We've been doing these since January. We started out with brain health. We've gone through a few legal helpful hints and medications, and we formed this series really based on our desire to be a friend to the community, particularly all of us who are aging and have questions around these topics. So welcome to this community education series that we'll be having a few more months. We won't have one in December. So a little bit about Nazareth Home. We have two campuses in our organization. We're in Clifton as well as here. And I always say we have everything that you think about when you think about care, congregate living situations that people need. We're very active in the recovery program. A lot of us have surgical procedures, or we have a hospitalization, need a little bit of help getting ready to get back home. And then of course we do all the things that we think of in the end of days. We're very committed to that palliative program, end of life programming. We have a strong relationship with hospice and palliatives. We have a wonderful memory care program. Our program is a bit unique, sorry to you guys, it's female only. And we love to offer that care and services. And then we have what's called personal care here in Kentucky, which means you need a little bit of help. It's a little bit more than assisted living, a little more medically based. And then on the Clifton campus, we have independent living. So we're proud of what we do. We're very committed to it. We've been here, this building has been here since 1976. And we have been strong in reputation and commitment to the Louisville community and offering programs as we do. So it's and I always want to welcome you to our website, nazarethhome.org, and we invite you to visit there. Maybe you did as you were coming here this afternoon. So it's my privilege and honor to introduce Dr. Pat Murphy to you. Dr. Pat Murphy, I credit Dr. Murphy with really building a community of geriatric medicine here in Louisville. He worked at University of Louisville Medical School. He was one of the first geriatricians that really had an active practice here in Louisville. He taught residents. He was on our Clifton campus for many years as the medical leader and teacher. He was part of forming many of the services that you continue to see at University of Louisville in geriatrics. He chaired the local American Medical Director Association. We tried to wrangle a lot of people coming to those meetings, not just physicians, but other nurse leaders. There was a time that I think we had almost all the medical directors in town, and all the directors of nursing would come to those meetings with Dr. Murphy's leadership. So I really credit him a great deal for a lot of things that I know, for many things that the staff who work within Nazareth Home go about doing. So it is that philosophy of wellness, that aging is not a disease. It's something we all, if we're lucky, will experience, and there's some ways to stay well. So these topics, as I said, have really been popular demand, and certainly talking about fall prevention is something that we're all interested in, because it really can be a life-changing event as we age. So join me in welcoming Dr. Pat Murphy.
Well, welcome everybody. Thank you, Mary, for that introduction. I walk around a little bit when I talk, so you all have to bear with me on that. Before I get started, how many here will admit to being over the age of 65? How many of those that put their hand up have fallen in the last year or so? Well, we got a lot of upright citizens here. That's good. Okay. Well, I do talks on falls a lot, even though I'm retired. And because it's a real common, very common problem. And it's hard to keep people from falling. It truly is. But we do our darndest to do that. So, what is a fall? Now, it seems like it's pretty simple, but it's not. You know, a fall can be going from someplace higher to someplace lower. It doesn't necessarily have to be a fall. Now, from on the floor or down the steps or anything like that. I'm going to talk a little bit about my mother-in-law who's a patient here. And I told her I was going to use her as an example. I didn't tell her I was going to use her as a bad example, but I told her I was going to use her as an example. And of course, one of the things she's done is fall. But she told me, no, I slid against the wall and I went down on my bottom. I did not fall. That is a fall. No matter what she said. So, now most falls are not associated with passing out. That's a whole different ballgame. And I'll talk a little bit about that as we go along. And it's one of the most common geriatric problems that we've had to deal with, both in the nursing home and in the community. Now, so why talk about falls? Well, like I said, it's very common. In the community, 1 out of 3 people over the age of 75 fall every year. 1 out of 3. Half of these have more than one fall. So I always say if you've fallen once, you're going to fall again. So, we do everything we can to prevent that. Up to 25% of fallers admit, I think it's higher than that, but they admit that they've slowed down housekeeping. They don't go to the grocery anymore. They don't do a lot of things because they're worried about falling again. My mother-in-law had fallen 3 times. By the time she fell the 3rd time, her world consisted of the living room where the TV was, Fox News, and kitchen and her bedroom. That's it. That's what her world was. And when people do this, when they stop going out to all these places, they get weaker. The less they do, the weaker they get. When they get up and try to do more, then they fall again because their muscles have gone to jello. And this is really catastrophic in a lot of different ways. As my wife said, first you don't, then you won't, and then you can't. And that's what happens on these patients like this. And that's from my wife, 2021. So I told her I'd give her credit for that. So where do they happen? Well, as you'd expect, about 60% happen inside the home. And we'll talk about where inside the home too. 30% outside in the community setting. My mother fell going up to church, fractured her pelvis. 10% happen in a healthcare center like hospital or clinic or the nursing home. And I had several patients fall on their way to the doctor's office, especially in the cardiologist's office. That seems to be the place where people like to really fall. Okay, so more bad news is that it's a leading cause of fatal and non-fatal injury in the 65-year and older age group. So it's when we talk about falls, we talk about falls because they are deadly. If you talk about the death rate, it's 10 per 100,000 in the 65 to 74 age group. That doesn't sound like a lot, but then when you get up into 85 and older, it goes up 15 times. And that's a lot of patients that fall, and a lot of patients that get injured. Now, In the nursing home, you know, you may think that in the nursing home people don't fall. They do. I mean, you know, there's just no way that you can keep some of these people from falling, even if you had them 24/7 nursing care. It just happens. And 50 to 60% in a nursing facility will fall every year. You'll have that many falls. And of those, quite a number will sustain an injury. 11% will sustain an injury. So I put this, in spite of restraints, I put that up there for history. When I first started practice back in the Middle Ages and started doing nursing home work, nursing homes were basically a warehouse for older folks, you know, and God's waiting room. Basically, that's all they were. And patients got restrained if they were confused, if they were disoriented, and they were restrained both with chemical restraints like drugs and also with true physical restraints. And physical restraints and chemical restraints did not keep them from falling. In fact, when they fell, they had much higher incidence of injury. And so I put that in there because nursing home care has changed so much since when I started. And as Mary said, I was involved with a lot of that. I am proud of that fact. Now, what happens when people fall? Well, of course, they have an increased use of medical services because they go to the hospital, they go to the emergency room, and so they have increased use of medical care. They have decrease in functional ability. You know, as I've mentioned, they fall and they stop moving around as much, then they get weaker, then they fall some more, and so this is sort of a vicious cycle. They fear falling. Half of those who fall cannot get up without help, if they can get up at all. This is called what they call in medical literature is the long lie. And the long lie is basically tells you that this patient is not going to do well, that this is the start of the spiral downward, no matter what you do. And it's always a bad sign. And a lot of these people do end up in the nursing home. Because they can't take care of themselves. And unless they've got family that can stay there 24/7, which very few people do, then they end up in a facility. Now, cost of falls is tremendous. Now these numbers are about 8 years old. I have not gotten any recent numbers, but the numbers are going to be about the same. From the CDC, about $50 billion is spent a year on non-fatal injuries, fall injuries. In those 65 and older, $754 million is spent on fatal falls. And those people that, that fall, they have bleed into their head, or they have some other major difficulty, and they go to the hospital and spend some time before they expire. And so that's where that money comes from. Now, of those people who have the non-fatal injuries, about $29 billion is paid by Medicare, about $12 billion is paid by private insurance or out of pocket, and then $9 billion is paid by Medicaid. Okay, so that's a lot of money. A lot of money from your taxes is going to things like this, and it's you can't go into the emergency room for anything without coming out with a bill of at least $1,000. I mean, it just. Am I saying that's right? No, I'm not. But I'm telling you, that's what happens. my mother-in-law fell here and struck her head and had to go to the emergency room and get sewed up. And I think she came out of there with about a $3,000 bill. That's not. Oh, how are you? I didn't see you come in. Good to see you. I'm an old fart, so I know a lot of the people around here that have worked in the nursing homes before, especially at the Clifton unit, which was Sacred Heart when I took care of it. So who are the followers? Well, there's one of the things that you can't do anything about is the most common cause of falling is increased age. There's something to be said for living longer, but that does increase your risk. That's the biggest increased risk for falling is the aging as you get aging. Women are more likely to fall in the community than men. Now, why is that? Well, I think there's a couple of reasons. Number one, women live longer than men by about 7 years. And then two, the women have a tendency to be taking care of their spouses at home because the men get more frail than the women do. And so the women are taking care of their spouses, they have a tendency to fall, and then they end up in the hospital. Now in the hospital, it's men fall more. And that's because they don't have the spouse taking care of them 24/7. So I always thought that was an interesting statistics. The hospital fall rate is 17 per 1,000 patient days. And that doesn't sound like a lot until you start thinking how long patients stay in the hospital. And all of a sudden, 1,000 patient days adds up very, very quickly. So that's a lot of falls, Now, who else falls? Those who live alone have an increased risk of falling. Those who live in specialized housing like assisted living, personal care, any type of housing like this, where patients are older and have to be taken care of. Patients with multiple illnesses or multiple disabilities increases their risk. Patients with dementia fall more, and that's, these patients they don't realize what they're doing. They do things that impulsively, and so they fall. This is one thing that Dr. D might have talked about a couple of months ago, but patients that are on more than 4 prescription drugs have an increased risk of falling. And when you think about that, it doesn't take long to be on 4 prescription drugs. You're diabetic, you're on 2 drugs for that. You're hypertensive, you're on 2 drugs for that. You've got heart disease, you may be on 2 or 3 drugs for that. And that's also if you're taking an expensive aspirin. Okay, urinary incontinence increases your risk of falling. Now that's a couple reasons for that. Well, number one, if you're incontinent, you have a tendency to try to, make it to the bathroom. So you're running to the bathroom and you trip over the threshold and you fall. The other thing with urinary incontinence is you may not make it to the bathroom, there's urine on the floor, and then you slip and fall. And I've seen both. I'll never forget going on a home call in downtown Louisville when I'm going down to see this lady. She knew I was coming, but didn't answer the door. I walked in and she was on the floor. I kneeled down to take a look at her, and the carpet sort of squishes underneath my knee, and the whole carpet was like that. And as she's incontinent, she fell because of that, and she went to the hospital, but she did not come out of the hospital. Inability to carry out more than 2 basic activities of living. This is bathing, dressing, eating, toileting, transferring, incontinence. only due to or less than your increased risk. Psychotropic drugs, I'm going to hit that again and again, and I'm sure Dr. Andemasiris did that too. Psychotropic drugs are a disaster. Now these, excuse me, we talk about psychotropic drugs, we talk about sleepers, we talk about anti-anxiety agent, we talk about antipsychotic agents. I will tell you that I hate sleeping pills in elderly patients. They make them confused, they make them fall. Most of the time, 99% of the time, they don't need them. They don't think they're sleeping at night, but they really are. So you'll hear me off and on talk about sleepers. Now, rarely is there a single cause of falling. It's usually due to the effect of multiple impairments and disabilities, like I mentioned before. So when we look at falls and we try to make some sense of them, we split them up into extrinsic causes and intrinsic causes, and this is just an artificial way to look at falls. But it's trying to make complex problems simple. We try to do that a lot. So if we look at intrinsic factors, the first thing I'm going to talk about is age-related factors. And these are normal aging problems, okay? First of all, you lose some of your ability to multitask. And this is a normal aging. And it doesn't mean you can't walk and chew gum at the same time. That's not what I'm talking about. But when you can't, for instance, you can't talk on the cell phone and talk to your granddaughter and try to cook eggs at the same time because you're going to do something stupid and fall, okay? And that's what I mean by multitasking. Aging also impairs the central mechanisms for postural reflexes. And what are postural reflexes? You know, when you're sitting down like that for any length of time, blood has a tendency to pool in the lower extremities. When you stand up, your postural reflexes push that blood back up to your heart and to your head. As we get older, that doesn't work as well. In fact, sometimes it doesn't work very well at all. But in aging, you commonly lose some of this, so you have to be very careful when you get up out of the chair and you've been sitting for a long time. And I'll try not to keep you in your chair for a very long time. But anyway, our getting out of bed in the morning is real common. Now, proprioception also decreases with age. What's proprioception? Proprioception tells us where we are in space, okay? My proprioception is telling me I'm standing up, my cane's helping hold me up, and I'm going forward and backward. But as we get older, that doesn't work quite as well, so that increases our risk of falling. Our light-dark adaptation gets worse. Now, a good example of this is in our condominium unit, the elevator is made of dark wood. So you come in from sunshine, and you come in, everybody does this. You come in from the sunshine, you get into the dark elevator, and you try to find your floor, and you're all the way up there looking. And it's amazing. We all do that. But another example of that is when you're driving, and you're driving in the sunshine, and you're going into a parking garage. When you first go into that parking garage, you can't see squat. And you have to stop and let your eyes adjust, otherwise you're gonna hit a pedestrian or hit another car. And even though the guy behind you is beeping, it's best to wait, okay? Best to wait. And that is normal aging, unfortunately. Glare isn't tolerated as well. Bifocals, sometimes, some people don't do well with bifocals. when they're trying to see where they're going, and they miss steps, they miss they miss things on the floor. So sometimes people don't adapt to bifocals very well. Now, changes in hearing are common. All you have to do is go up on the floor and walk down the hall, and you can hear Fox News coming from every closed door. I mean, it's just amazing. And while they're all watching Fox, I have no idea. But all you have to do is walk down that hall. But, the hearing problem, we use hearing, believe it or not, to judge distances. We use hearing to judge how fast the car is coming at us. We use hearing to judge people walking up on us. There's something called the startle reflex with hearing. An example of this is you're standing there, not a problem. You don't hear somebody coming up behind you and they say, "Hey, Dr. Murphy," and you jump 3 feet in the air, and then you fall. And that's because, my hearing wasn't working. They scared me to death, and down I went. Now, there are also, when we talk about hearing, we also got to talk about the vestibular system, because that's in the ear too. And as we get older, that vestibular system doesn't work as well. So, what happens is, when we're standing here, we all have a little bit of sway. We all have, just a little bit of back and forth. You don't even notice it. But as we get older, that sway gets worse. And so it's very easy if you're swaying and somebody comes up and punch you on the chest a little bit for you to go, depending on how you're swaying at that time. So that's a normal aging, unfortunately. Okay, now problems with gait. And these, again, are normal aging. There's, of course, abnormal aging with gait that are involved in this too. But we have decreased speed of our gait. We slow down. We have decreased length of stride, or we walk more with the feet closer together when they land. We have a decreased range of motion of the hip and the knees and the ankle normally. Now, it's even worse if you've got arthritis. It's even worse if you've got anything else going on with the joints. But normally we have some decreased range of motion there. Now, remember, irregular surfaces are not your friend. What do I mean by this? Well, you notice I'm using a cane. Well, what started my cane was that I was walking down Cherokee Road with my wife, and you know how the sidewalk gets lifted up by the roots? Well, I didn't lift up my foot far enough, so I tripped and tore my quadriceps tendon. Had to have surgery on that, healed up all right, but then a few months later I got an infection in it. But that's. Irregular surfaces are not your friend. Even if you're not on a cane, it can be very, you go out in the grass, you go out in the gravel, it's very easy for you to lose control because of that. Other risk factors, as we get older: cataracts, glaucoma, macular degeneration, any type of visual problems, peripheral neuropathy. If your feet are numb, you can't tell where you're going very easily. Gait disorders like Parkinson's disease, osteoarthritis, I already mentioned, osteoporosis, bunions, foot problems, any type of acute illness has a tendency to make you fall because you get weak. And that, if the norovirus is running around the building and everybody's having vomiting and diarrhea and get weak from that, you'll have a lot of fallers then. Denial of problems. And, denial is not just the river in Egypt. denial of problems is one of the hardest things to deal with on older folks. You know, older folks like their independence like anybody else. And so they're going to deny that they've got any problem with getting around or seeing or hearing, or because they want to stay in their house. My 95-year-old mother-in-law said the only way she was going to go out of the house was feet first. And she almost did. The third fall, she had, you know, a couple of fractured vertebrae. And she lives in Paducah, or lived in Paducah. And we'd been trying to get her to come up here with us for ages. But when she did that, that was it. We got her up here. My mother-in-law is a retired second shift nursing supervisor, and she worked in a hospital. You know, I think she retired 30 years ago. But in the time when she was a nursing supervisor, the second shift nursing supervisors were basically the boss. Doctors and administrators were just ancillary personnel. The nursing supervisors were the one that makes all the decisions, and she still tries to do that today. I'm glad I'm sorry with some of the aides around here that have to take care of her. But you didn't hear that, Betty. No. Now, let's talk a little bit about the postural hypotension, because this is not uncommon. And this is when I talk about postural hypotension, this is when you, sitting for a while, you stand up and then all of a sudden you feel like you're going to pass out. You get lightheaded and you feel like you're going to pass out. And that's because blood's pooling, it's not going back up to the heart or the brain. About 20% will get this in the community at one time or another, and there's a lot of different causes of it. Up to 50% will get this in the nursing home. And the reason for that is most commonly because of medicines. You know, there's a lot of different medicines that will cause postural hypertension. Most commonly antihypertensives and cardiac meds. And so one of the things that I always taught my residents and fellows is that no matter what you do when you first look at an elderly patient, is look at all their medicines and see what they really need. Because a lot of times, these medicines sort of accumulate, what I call pharmacy creep. You know, they go in for hypertension, you put them on a medicine. They go in and they've got a bad cough because of antihypertensive medicine. So now you put them on something for the cough. And then it's just that way. And so you have to be, one of the things that geriatricians do well is making sure that we try to decrease meds. We have to make sure that we know all the drug-drug interactions. We have to make sure that we know what side effects there are of drugs so that we don't overdo it on our patients. But, you know, meds cause that very commonly: dehydration, infection, cardiac problems. And most of the time it's multifactorial, but if you can work with the meds, that's one of the first things that I look at. Now, extrinsic forces. Gee, I was just talking about these. Drugs. This is one of the first things that you should always look at. Always look at, always look at every time that you see this patient. Especially pain medicines, psychotropic drugs, sleeping pills. I hate sleeping pills. Blood pressure medicines and diuretics, other cardiovascular drugs, extrapyramidal symptoms of antipsychotics. Some antipsychotics give you almost Parkinson-like syndrome, where you have the shakes, the tics, the problems with the gait. And so any combination of these can cause problems too. So again, drugs, drugs, drugs. Now, let's talk about stairs. I'm going to talk about my mother-in-law again, okay? Bear with me.
You're gonna owe her money in a minute.
I told her I would. I told her, you know. She actually owes me quarters from when I take her wash home and do it. And for a while there, our dryer was out, so I had to take the clothes to the dryer and put a bunch of quarters in. And at this time, she was winning all these bingo games and getting quarters in. So she owes me. I don't know her. But anyway, at her house in Paducah, the washing machine and dryer was downstairs in the basement. The stairs were like that, and I'm not exaggerating. So what she would do is she would bundle up the clothes and she would throw them down, and she'd get it down there, and then and so there was only one handrail, so she'd go down the handrail, and get down there and get the wash in there. And luckily there was a place for her to sit and watch Fox News for a while. And so then she bundled up the clothes and take them up the stairs. And so she'd go up one stair, bundle clothes. Another stairs, bundle of clothes. We expected the phone call that she was at the bottom of the stairs, but she somehow got away with that. I don't know how. But most stairs are poorly lit. Some stairs don't have any handrails at all. Steep, yeah. Rugs on stairs can be a disaster because if they're tagged down, sometimes those little tags come up, and so then they slip on that. Descending the stairs, going down the stairs, is most commonly the cause of falls rather than coming up. But I always thought that was interesting, the way she did her wash. Now, other common household problems. Most commonly household problems, the falls are caused by tripping in the house. Pets, furniture, electric cords, door thresholds, especially in the bathroom. This is, I think, more commonly where a lot of the falls occur. That's on the way to the bathroom and usually at night. Yes, grandchildren cause falls. I don't know if you all have ever had the 4-year-old grandchild come in, Papa, hit you right at the knee level and knocks you down. I mean, you can't help it. And they don't do it on purpose, but they can do it. Now, loose throw rugs. There should not be a loose throw rug in the house. It's just too big of a risk. And if an occupational therapist goes in to review the house, that's the first thing they look for is throw rugs. Low toilets. If you really want to do something for your aged mother or father or whatever, buy them a high toilet. I mean, it's not a sexy thing, or it's not a great gift, but you can. It doesn't cost that much, and low toilets can cause problems. I've had people try to sit down on low toilets, miss, fall, break their hip. I've had a couple of patients get on the low toilet and then can't get off. And I had one that was on there for almost 6 hours, and of course they had a decubitus ulcer on the butt by the time that we got him off. And so, low toilets can be danger. And like I said, I do mean not the little portable high toilets. I mean, you can use that, but just get them a higher toilet. Bathtubs, I know they've got these walk-in bathtubs down. I guess they're okay. I was always a believer in having the shower so that they could walk into the shower. And that's something else you could do for your family member. Now, in the nursing home, most of the falls are in the patient's room, of course, and most of the falls are in the bathroom. It's just, they're usually at the threshold. And then again, meds. Okay. Now, when we look at the history, there's a lot of things we ask real quickly. What were you doing at the time of the fall? Getting up, getting out of bed? Were you feeling ill before the fall? Did you have any palpitations or dizziness? Did you black out? I'm going to talk about that. What was the time of the episode? Was it early in the morning when you're getting out of bed? Or was it a couple of hours after you eat? And the reason that you ask about that, there's something called postprandial hypotension. And that's when people, they eat a big meal, and 1 to 2 hours after their meal, their blood pressure will drop because the blood is shunted to the intestinal system. Okay, and that way they can get hypotensive from that and fall. Any neurologic symptoms? Was this a TIA? Use of meds. Alcohol. I want to step aside and talk a little bit about alcohol in elderly patients. There's 2 spikes of alcoholism. The first one is usually, in the late teens, early 20s, 30s. But the second spike is in late 50s, 60s, 70s. And it's most commonly in males, most commonly in widowed males, most commonly in Caucasian widowed males. And the reason for this, of course, is these men, the 5 o'clock highball turns into the 4 and 5 o'clock highball, turns into 3 and 4, 5 o'clock highball, turns into the, whatever. And all of a sudden, they're drinking a lot. And a lot of these guys are closet alcoholics. They hide it very well. But if you can see these guys and get treatment for them, they are much more amenable to treatment and stopping alcohol than the 20-year-old. And so it's very important that if you know that someone in your family may be doing this, get treatment, because they'll usually react well to treatment. Cardiac problems, including rhythm disturbances, we'll talk a little bit more about that. Now, there's something called, if we look at the gait and balance, something called the Romberg test. The Romberg test is they put their feet together, put their arms out, and then you wait and see if they're going to fall. You also make sure that you're holding underneath their arms. But that sort of tells you how well their vestibular system is working. You look at footwear. One of the things that you want to make sure is that they've got a good sole on their shoe, and maybe some grip to it. Slippers, to me, are aptly named because 2 reasons. One, they don't have a sole and they slide around when you walk. The other thing is they wear out pretty quickly, and so your foot starts sliding around the inside. So slippers you have to be very careful. LL Bean has some nice slippers with good soles on the back. I don't have stock in LL Bean. I just know that they've got some there. Mini mental status exam is you think the patient's got some underlying dementia. If the patient can walk, I like to see them when they came into the clinic and see if they could get up on the table without help. That sort of gives me a general idea how they're doing at home. There's also a get up and go test that we use, and it's really simple. Most people can do it in about 10 to 15 seconds. If it's greater than 10 seconds, they've got an increased risk of functional disability. And so what this does is you let the patient sit down in a hard-backed chair so their feet touch the floor, no arms rest. You let them get up, walk 10 feet, turn around, and come back and sit down. If they do that, it takes them over 20 seconds, then that's a good risk for falling, good risk for functional dependence. Now, how to keep upright. I wish I had some really good things to tell you about how to keep these people from falling. But, you know, there are some things we can do. First thing we can do is, I've already talked about some, and that's doing environmental modifications. Non-slip surfaces, securely fastened handrails on both sides of the wall as you're going down. Sufficient light, that's very important. Accessible call light, I had to put this in here because, you know, when you go into the patient's room in the hospital, this was always big in the hospital. This was one of my pet peeves in the hospital. You go in the patient's room, the patient's in the bed, and the call light is over here on the chair. So how in the heck was the patient supposed to get help with the call light when it's over there? They try to get up and they fall out of bed. And you see it sometimes in the nursing facilities. It's not as bad in the nursing facilities as it is in the hospital. Now, help by falling and I can't get up. I know everybody's seen this commercial, but actually, those things are pretty good if you can get your relative to use it. Could I get my relative to use it? No. I mean, we were going to pay for it? No. I don't wear that. Okay. Now, a cell phone, if you can get them to use a cell phone and carry that. Did my mother-in-law let us get that for her? No. So, anyway, those are things that if they'll let you do it, do it. Chairs are proper heighting with armrest. You know, the best kind of chair is the straight back chair. Make it so that their feet are on the ground. They have good armrest, and so that way they can push themselves up out of the chair. Couches are horrible for older folks because, of course, they've only got one armrest, and usually couches are sort of a lot softer than these hardback chairs. And some people, they get down there, they can't get up. And so if you can at least get the couches, have them not use the couches. And then you really need low-lying objects like coffee tables. You know, because the coffee tables come at what, mid-shin, and people forget about those. Now, bathroom modifications. And if you can, again, if you could do nothing else, modify the bathroom as much as you can. Make sure that the door is wide enough so that you can get a walker in, you can get a wheelchair in. Skid-proof strips or mats in the shower. Grab bars. Toilet, tub, shower grab bars. And these really do work. I mean, they're very good. Elevated toilet seat. And then American Disability Act accessible. About 12 years ago, I think, I was walking home, crossing Bardstown Road and Baxter and Highland Avenue, and I got hit by a plumber's truck, you know, and besides 5 broken ribs and a broken knee, you know, I did okay, but with the insurance company's money, we modified 2 bathrooms and made them accessible. So there was a good part of that anyway. Now, some American Geriatric Society guidelines, and they're not many because there aren't any good studies that show something is really good about keeping people from falling. So if you keep somebody from aging, they won't fall. But good luck with that. Let me know how you do. Okay, Tai Chi has really, now this is one thing that studies have shown to help keep people up. So if you can convince them to go to take Tai Chi classes. That does help. I know that we live close to Cherokee Park, and there's right there in the Triangle Park, and then also on the other side, I see Tai Chi classes all the time. And so they do help, they do work. Gait training with appropriate devices. If you've got a patient that's weak, got a patient that has fallen and maybe not hurt themselves, and then get them set up with outpatient physical therapy, occupational therapy. Train them in appropriate devices, and we'll talk about the appropriate devices. Make sure that you know they don't have postural hypotension. Check for that. Modify the environmental factors. You can send an occupational therapist in to evaluate the home and make recommendations. And I'll tell you, the first thing they'll say is get rid of the throw bugs. And then modify meds. I know you're tired of hearing that, but medicines are good in the proper amount and without overdoing it. And so it's very needy to check on those meds. If you've got a patient in long-term care, staff education on how to get these patients up and moving, and gait training is what they need, okay? So it's very important that even the aides know how to work this. Meds review, as I mentioned, when I had the fellows and the residents work with me, the first thing that they did was look at the medicines. And do they need these medicines? And then footwear, we need to look at footwear. I think the other thing, and I don't know if any of y'all been in the hospital, but you know when they go in the hospital, they give you this bucket with toothpaste. They give you these socks that have these little strips on the bottom. They're totally worthless. I mean, I wouldn't wear them. They won't help keep you upright. But I guess they think that's doing something. I don't know. But don't wear them. Take your own shoes with you. Mobility aids, canes. Lightweight, easy to use. Unilateral support. Up to 15 to 20% of body weight can be supported by a cane. Canes are cheap. You use it on the opposite side of where your bad leg or whatever is. And even with the use of a cane, you need to get physical therapy involved, okay? You need to get physical therapy involved. And you can replace the tips all the time. I do. I wear out a tip every couple of months. So you don't have to buy a new cane, just put on a new tip. They're cheap too. Okay. Now, walkers. Bilateral support. It can basically support your body. But we must remember that when we've got these patients using walkers, it takes a lot of energy to use a walker. It's not like they can just pick up and go. They're going to be slow because they're going to wear out quickly. So it's very important to remember that. So your mom's not being ornery and cantankerous when she, is using the walker slowly. It takes a lot of energy to use that walker. Gait is much slower. There's multiple types of walkers. There's the 4-point walker that everybody puts the tennis balls on the front. There's a walker with 2 wheels. There's a walker with 4 wheels. There's other specialized type of walkers when you've got a fractured arm that you have to put in. So you really need physical therapy anytime that you've got this. Exercise, as I mentioned, Tai Chi works, does seem to improve balance. The object of the game of any type of exercise is to keep moving forward, not backwards. And anything that you can do to keep people on their feet and keep them going is the best thing. The worst thing for an older patient to do is to sit down and watch Fox News all the time. You know, that just, you know, they're gonna get weak. Physical therapy, exercise, and balance training should be offered to any of you who fall, or even if they're high risk of falls, Medicare will pay for some of the outpatient physical therapy. Unfortunately, there's no good consensus on the best type of exercise for elderly patients. So the only thing that everybody agrees on is Tai Chi. So, I mean, but I think anything that you can do to keep a patient on their feet is good. You know, and I talked about the environmental assessment by the occupational therapist already. Let me reemphasize that, because they can go in and make recommendations to keep people from falling. Now, other interventions, osteoporosis should be considered if these people are at increased risk of falls. Some falls have cardiac causes, especially those without evidence of self-rescue. Now, when I mean evidence of most people, when they know that they're going down, they try to stop themselves. A lot of times with cardiac arrhythmias, these patients don't even know they're going down. 1 minute they're up, and the next minute they're down, and they don't know that this happened, or what happened. And so, when you have a patient that does that, you better start looking at their heart. Look for identifying any sight or other sensory loss. Meds. Out one floor living, if you can keep them on one floor. And then family backup again, if the patient agrees. And I will step aside here and say, don't feel guilty when you try to do everything that you can with your loved one, and they won't do what needs done. And then they fall and have the disaster, and then you feel guilty. You've done what you can. If these patients are cognitive, they make their own decisions, and I don't mean to sound harsh, but you can't beat yourself for something like that when they've made the decision. You can gripe at her later on. Vitamin D, it doesn't take much to get these patients have vitamin D. Take them outside for 10 minutes twice a week. You don't have to put them on all this medicine. Just take them outside, even when it's cold. Bundle them up. When it's sunshine outside, take them out. If you're going to use vitamin D, 400 units every day, I'm not a big believer in that, as you can tell. I'd rather get them outside somehow. Calcium citrate or citrical, with or without food, is better for those with absorption difficulties. Calcium carbonate, which is Tums, you take with food or for better absorption. No more than 500 milligrams at a time. Okay, and that's sort of all I've got to say. I'm happy to entertain any questions. I might not have answers to them, but if I don't, I'll tell you.
Did your cane come as a result of a fall?
Yes, I had a fall that tore my quadriceps tendon, and got it all healed, and was back to work. And 4 months later, I had what was called pneumococcal sepsis, and the pneumococcal bug seeded that knee, and then I ended up with 3 more surgeries and all sorts of antibiotics and stuff. So it took me a year. I was talking to somebody else. It took me a year to get this to this what I can do now.
Infection.
Yeah. Anything else?
Not a question, but instead of the Help I've Fallen button, I've gotten myself an Apple Watch that will alert people if I fall or if I move my hand too fast. It asks me if I've fallen, and you can wear it in the shower and even when you're sleeping.
I should have brought that up. It's very good. My son keeps telling me about that. He's more of a computer expert. He's an engineer, I'm not. But that's it.
easy.
Yeah, that's what he says. That's what he tells me. Dad, you just got to get you one. He likes his because it'll read his EKG too. You know. Anybody else?
Are you like Betty with the watch and your son?
Am I like?
I said, are you like Betty?
Oh, well, no. I just I carry a cell phone around with me all the time. You know, and so I do that, and my wife is at home with me, so she usually keeps me out of trouble most of the time.
I have a question. You were talking about the socks with the skin things on them. You did not like those. So if someone is, for the most part, in a bed, in a facility, what do you recommend for their feet?
Well, are they getting up at all?
Very,
Very little.
Yeah.
Well, I would still, if they do get up, I'd put slippers with the sole on, with maybe a little bit of a little bit of I don't know what I'm trying to think.
Stretch open.
Well, tread.
Okay.
That's, I'm really not kidding about slippers and slipping.
I don't guess you like flip-flops either, huh?
No.
No. No, I don't. I'm glad you asked. Yes, ma'am.
You talk a lot about the medications and interactions between medications. If you're going to multiple types of doctors, who do you go to ask how do all of these medications interact with each other?
I would say your primary care physician. You know, because she should know all the drugs that you or whoever is on. And because sometimes I go to a cardiologist. Sometimes the cardiologist doesn't know I'm on this and this and this, even though I tell him, and so when you go to your primary care, whoever, they should know the whole list of drugs. Now, the other thing, I'll step aside and talk about this now. I think if you're on several medicines, I would definitely carry a card around with all the medicine list and your diagnosis on and put it in your wallet. And then have your spouse carry it too. But your primary care physician should be the captain of the ship. Well, that happens. You're going to a cardiologist with your heart disease, you're going to orthopedic surgeon because you're going to need a new hip, and so it happens. Yes, ma'am.
On the list of medications, you should also put down any allergic reactions to
Right.
medications you have.
Right. I agree. I've got that on mine too. Yes, ma'am.
Our mother would be your mother-in-law.
No, I'm sorry. No, I love my mother-in-law. She, Betty. You hear that, Betty? But
After the third fall,
Yeah.
and no broken bones, but cuts and black eyes,
Right.
when they get home, does it take usually a hospitalization to get them to, or you can't reason with the fact that they don't live home?
well, that's a good question. Some of them it doesn't. Some of them, no matter what you do, even hospitalization. I'll go to rehab for a while, but then I'm going back home. And again, I will tell you, it's not your fault that they've made the decision like that. And it sounds harsh, but
There's good in it. There's good in it.
Right.
Some good in it.
very little, but some. But I had told my mother-in-law a couple of years before this that I said, we can't keep driving 4 hours down here to Paducah. you know, and keeping a check on you, but you know, it's snowing, it's ice, it's raining, it's a long drive, and and she remembered that. She brings that up to me a lot, but you do what you can do, and if they're cognitive, they have to take responsibility for their own actions.
I have one more thing I just want to say. My name's Heidi Yost. I'm with Anthem. If anyone here has an Anthem plan and it's Medicare or Medicaid, you're actually eligible for a free personal emergency response system. So if you're interested in that, or I can help you in any way get that, I would be happy to.
That's good. I didn't know that. I didn't know this one. Is that just for the Medicare Advantage plans? Or?
Mostly, yes.
Yeah.
But also Medicaid as well, decent.
Okay. Okay. Yes, sir.
So is balance then something that can be learned or
Can be
exercised?
you can help with balance and help with their reaction to their imbalance. If they've got vestibular problems, though, you know, you don't put them on an a vestibular agent, because that makes them dopey and makes it even worse. But there are some again, physical therapy can help with that. And my mother-in-law, that was one of her problems. The last fall that she had, she was looking up to get something out of the cabinet, and then she kept going backwards. And that's again, physical therapy can help with it. Can it make it go away totally? No. And some people would put people on some docs would put them on an agent that supposedly helps with dizziness, like Antivert, meclizine. That's a mistake. But I'm retired now. Don't take my word for it. Anybody else? Very good.